Welcome to Connected by Health. I'm Dr. Krishna. This is where medicine meets leadership, innovation, and humanity with one goal: to add value and help change healthcare for the better. If you believe health is about more than a diagnosis, you're in the right place. Today's episode is one of the most important conversations we can have in healthcare, and one of the hardest. We talk constantly about patient safety, quality metrics, outcomes, and costs. But today, we're talking about the people delivering the care, and what happens when the system quietly breaks them. This episode today is about physician mental health and physician suicide. It is about burnout, it is about depression, it is about moral injury. And it's about why this is not just an individual failure, but a system-level crisis hiding in plain sight. If you're a physician, a trainee, a nurse, an administrator, or a policymaker, this episode is for you. And before we go any further, I just want to say this clearly. If this topic is too personal for you or brings up difficult feelings, you are not weak and you're not alone. We'll share resources at the end of the episode. Today's episode, as we've already stated, discusses physician mental health and suicide. While we will not describe methods or graphic details, we will talk openly about suicide as a public health issue affecting physicians. If this topic is difficult for you or brings up personal experiences, please take care of yourself while listening. It's okay to pause, step away, or reach out for support. If you or someone you know is struggling, help is available. In the United States, you can call or text 988, the Suicide and Crisis Lifeline. We'll also share physician-specific resources at the end of this episode. Again, this is an episode that is not intended for substitute for professional, medical, or psychiatric or mental health care. This episode is intended for educational and awareness purposes only. The goal of this conversation is not to assign blame to any individual physicians, leaders, but to examine how healthcare systems, policies, and workplace cultures contribute to physician distress and what evidence shows can actually help. Talking about physician suicide can be uncomfortable, but silence has never protected physicians, and it has never saved lives. So let's start with the data, because the numbers tell a story we can't ignore. Physicians die by suicide at higher rates than the general population. Amongst male physicians, it's often 40% higher than non-physicians. Among female physicians, it's often 130% higher than women in the general population. In the United States, an estimated 300 to 400 physicians die by suicide every year. That's roughly one physician every day. That's roughly an entire class that graduates in a year. But differently, these are just the deaths we can count. Depression, anxiety, substance use, and abuse, and burnout affect way far more. Burnout prevalence is about 45 to 60% of the U.S. physicians. Depression affects 30% of residents and early career physicians. Suicidal ideation is reported by 1 in 10 physicians in some studies. This is not rare. This is not anecdotal. This is not confined to certain specialties. Burnout, depression, moral injury. We often use the word burnout because it feels safer. And burnout sounds like I'm tired, or I just need a vacation, or hey, my work-life balance is off. But burnout is not a medical diagnosis, and focusing on burnout alone minimizes the problem. Let's clarify. Burnout is emotional exhaustion. It is depersonalization. It is the reduced sense of accomplishment. Depression, persistent low mood, loss of interest, sleep and appetite changes, thoughts of worthlessness or death. And then we come to moral injury, which has become increasingly recognized. Moral injury is being forced to act against your professional values, knowing the right thing to do but being unable to do it. Repeated exposure to ethically distressing situations. Many physicians are not just burned out, they're injured. Why physicians are at higher risk? Physicians share many risk factors seen in other high stress professions, but with added layers. First off, perfectionism and identity. Medicine selects for the high achievers. Self-worth becomes tied to competence, and failure feels catastrophic. Access and knowledge. Physicians know lethal dosages. Physicians have access to medications, and suicide attempts among physicians are more likely to be fatal because of the access to knowledge. Of course, we cannot forget about the culture of silence. Medicine is very hierarchical, and oftentimes that rewards performance over health. Don't show any weakness. The patients need you. Others have it far worse. And we cannot forget about stigma and licensing fear. Many physicians do believe that seeking help will jeopardize their license. It will also affect credentialing, and it may trigger reporting requirements. And here's a very, very tragic paradox. Physicians who are trained to detect suffering in others, but not allowed to acknowledge it in themselves. Medical training itself is a very risky environment. It can be a very traumatic experience. Medical school and residency are high-risk periods. Residents work long hours with chronic sleep deprivation. Yes, of course, they have brought upon the 80-hour work limit, but let's face it, let's be honest. During the pandemic, how many residents across the country do you think worked greater than 80 hours per week? Quite a few, or actually way more than that, to be honest with you. Rates of depression often increase during the intern year, and suicide is actually one of the leading causes of death among resident physicians. And yet, despite all that, mental health education during the medical training is often minimal. Help seeking is discouraged implicitly. Mistakes are often punished. They're not contextualized. We train physicians in environments that normalize suffering and vilify vulnerability. Now, sometimes there's this assumption that some certain specialties carry higher risk. And of course, there's always some data that shows that may be the case in anesthesiology and in emergency medicine and psychiatry or surgery. But why is that? Why are these certain specialties considered higher risk? Well, one, higher acuity of level of care, higher responsibility, frequent exposure to death, and of course, very little recovery time. But to be honest with you, I really don't like viewing physician mental health and suicide as this specialty targeted approach. Because the truth is no specialty is immune. Primary care physicians experience crushing, and I can tell you that from personal experience, crushing administrative burden. There's a lot of time pressure to get the documentation done, a lot of time pressure to see more patients, and of course, emotional labor without support. You see, the problem when it comes to physician mental health and physician suicide, the problem isn't just the specialty. The problem is the system. And speaking of which, what role does the healthcare system play? Well, let's talk about what rarely gets named. Physician mental health is shaped by a variety of different parameters, but here are a few, though we often don't think of it this way, but here are a few that actually really impact physician mental health. Productivity quotas, right? RVUs per year. Electronic health record system burden. Up to 2 hours of documentation for every 1 hour of patient care. Prior authorization battles with the insurance companies. I can tell you that from personal experience too. Staffing shortages. Well, we're only going to give you one medical assistant or one nurse. You are not seeing enough to qualify for extra help. Moral distress from insurance denials. You see, physicians often report of feeling like cogs in a machine. They often report about the loss of autonomy. And of course, it is always in the back of every physician's mind, the constant fear of litigation or complaints. And yet, and despite all this, We do have some wellness initiatives, but here's the problem. They're not focusing on the right problems to address. They're often focusing on, let's do yoga. Why don't we give you a 20-minute break? Let's do 20 minutes of Tai Chi, or let's focus on mindfulness. I have learned how to practice mindfulness. I really owe it to one of my mentors, Dr. Murali Krishna, and it has helped me in my career. But the problem is you can't just practice mindfulness alone without really addressing all the other burdens, the documentation, the constant battles with the insurance company. Another wellness initiative has been resilience training. Now, all the ones I just mentioned, the Tai Chi, the yoga, mindfulness, resilience training, these are not bad ideas, but they're insufficient. You can't just meditate your way out of a broken system. You have to fix the system. But because we have a broken system, that's one of the reasons why physicians oftentimes don't seek help. Despite them knowing the risks, they just don't seek care. So let's talk about some of the barriers. Why don't physicians seek help? Well, first off, fear of documentation, the fear of being reported, the fear of being seen as weak or incompetent. Of course, time constraints. Hey, I don't have time to go see my behavioral therapist or my psychiatrist. And one of the most frightening barriers that we have towards physicians seeking help for mental health is the lack of confidential services. Who is this data going to? How is that going to impact me? How is that going to impact my licensing? Some studies show that over 40% of physicians would not disclose mental health on licensing forms because of that fear. Many of them choose to self-medicate instead of seeking treatment. But once again, this is a systems problem. It is a systematic issue. This is a policy failure. It is not a personal failure. So what does the evidence show as far as what helps? What works? And to do that, you really have to look at this really on three different levels: the individual level, the team-based level, and of course, the systematic level. So on the individual level, confidential, off-the-record mental health care, that is a must. People cannot live in fear of seeking help. And confidential, off-the-record mental health care would be the best way to do it. Peer support programs, those always help, especially people that know the amount of work that you're doing and have familiarity with how difficult your job is. Reduce stigma through leadership modeling. If you're a leader, and we'll talk about this later here in the episode, but it starts at the top of the ladder, and leadership must be held responsible to reducing stigma to seeking mental health help. On the team-based or institutional level, you're looking at removing intrusive mental health, specifically intrusive mental health questioning from licensing. And of course, create reasonable scheduling and protected time off. When you're looking at on the team-based models, you really have to help with adequate staffing. I know this on a personal note. When I have adequate staffing, I don't necessarily have to take the extra 100 steps on a day that I have to do to make sure clinic is running smooth. Policy interventions, standardized licensing language focused on impairment, not on diagnosis. It's focused on impairment. The government must also increase federal funding for physician mental health programs. We, as a nation, have to do this for everyone, but particularly for physician mental health. And the reason why is if the people who are supposed to be taking care of people are not able to take care of themselves, then we won't have those people to take care of us. There also needs to be improvements in national surveillance and reporting services. But all these show that physician suicide is preventable. But the problem is prevention requires structural change. Now, let's be clear. How can policy matter? How can leadership matter when it's talking about structural change? There's a lot that often gets lost in these conversations about physician mental health and physician suicide, because neither of them are really just individual wellness issues. They are issues pertaining to a leadership problem, a policy problem, and of course, a patient safety problem. Hospitals with high physician burnout oftentimes see higher medical error rates, They also see lower patient satisfaction, and they see higher turnover and staffing costs. Replacing a single physician, just one physician, can cost somewhere between $500,000 to $1 million, depending on specialty. Preventing burnout and suicide isn't just humane, it's economically rational. So, what can leaders do? Well, quite a bit, not just in the sense of symbolic means, but actionable means. Number one, fix licensing and credentialing questions. Remove questions that ask about mental health diagnoses. That is a must. Focus only on current impairment, not on past, not on diagnoses, not obsessing with treatment, but focus only on current impairment. Align with the Federation of State Medical Board recommendations. Fear of licensing consequences is one of the top reasons why physicians avoid seeking care. Second, provide truly confidential mental health care. There should not be any reporting to employers. There should not be any electronic health record documentation that's visible to credentialing. And there needs to be access to offsite or external clinicians. It would be great, but if there was also 24/7 coverage for night and weekend staff. Peer-reviewed studies have shown that physicians are far more likely to seek care when confidentiality is guaranteed. Third, treat workload as a mental health intervention. What does that mean? What that means is there need to be reasonable patient volumes. Hey, let's just go up on your average patient per day because we need to increase revenue for the health system. That just can't keep happening. We can't keep functioning as a system if volume is purely the only thing that leadership cares about. There also needs to be protected administrative time. Studies have shown a great degree of variability on how much, but some clause about protective administrative time is necessary. We also need to look at adequate staffing ratios. We also need to look at reducing non-clinical clerical work. And that might be also a task where we can look at the implementation of AI and leaders and health systems investing in AI to help reduce non-clinical clerical work. Because currently physicians spend up to 50% of their workday on documentation and inbox management, 50%. And reducing that 50% not only helps improve mental health, but it also helps allow the health system to have a more satisfied, to have a more healthier workforce. Fourth, normalize mental health at the leadership level. We need to have health leaders openly discussing therapy or burnout. And when you have leaders discussing about burnout and mental health, it helps everyone. Department chairs need to model help-seeking behavior. Removing punitive language around mistakes. People make mistakes, but when you create an environment that allows people to learn from mistakes, you have a more healthier organization and a healthier system. Because culture doesn't change from the bottom. Culture changes from the top down. There also needs to be policies and measures that actually matter. They also need to track burnout. They need to track depression, need to look into psychological safety. Because remember, physician retention is linked to mental health. And it's important to treat those metrics with the same seriousness as we treat infection rates or readmission data. So what can policymakers actually do? Well, we can't just leave prevention alone to hospitals. We can also have to look at on a different level in terms of healthcare policy. Number one, standardize licensing language nationally. Eliminate the state-by-state discrepancies. Focus not on the diagnosis, but on impairment. Protect confidentiality. You see, states that revise licensing language have seen increased help seeking among physicians. There also needs to be a greater amount of funding for physician mental health programs. And we need to look at federal and state grants that are for peer support, crisis services, confidential care networks, and also expand programs similar to the physician support line. Right now, What's sad is many of these programs exist on temporary or philanthropic funding, and we can't have that. Policymakers also need to address the systemic drivers of moral injury. And of course, primarily, this starts with documentation. We need to make documentation more simple. Well, there needs to be greater degree of prior authorization reform. And there also have to be development of payment models that prioritize time, not volume. Physicians have always consistently cited insurance barriers as a major source of moral distress. Policymakers also need to look at improving data collection because we still do not have any accurate national tracking of physician suicide. There need to be standardized reporting mechanisms. You can't solve a problem if you refuse to measure. And so, a direct message to all those healthcare leaders and policymakers. If you oversee physicians, regulate them, or even just write healthcare policy, this is for you. Physician mental health is not optional. It is a must. We need to address it. It is infrastructure. Every policy that increases workload, every policy that increases fear, or silence that increases risk, every policy that prioritizes safety, dignity, and support saves lives. That is what we need to have policymakers look into. In conclusion, if you're listening to this as a physician or a provider, you're not weak. You're not broken. You're responding normally to an abnormal environment. And now, if you're a leader or a policymaker, physician mental health is patient safety. Once again, physician mental health is patient safety. It is workforce stability. It is a moral obligation. And now, if this episode has brought up some difficult feelings, we apologize. But in the United States, you can seek help. Call or text 988 for the Suicide and Crisis Lifeline. Some physician-specific resources include the Physician Support Line, 1-888-409-0141. That's 1-888-409-0141. Confidential, free, and staffed by physicians. Physician suicide is not inevitable. It is shaped by culture, policy, and leadership. That means it can be changed. If you shape policy, act. If you lead healthcare, protect your people. If you practice medicine, stay. Fight the good fight. Seek help. Physician mental health and physician suicide are shaped by culture, policy, and choices. And of course, once again, that means that we can change it. Because we cannot continue to lose healers in silence. Talking about this saves lives. Changing systems saves more. Medicine needs your humanity. Thank you for listening. If you found this conversation valuable, share it with someone who could use it. And if you're on Apple, we'd love to hear your favorite takeaway and a review. See you next week.